Hey y'all, what's going on? It's your boy Mike here with another video. So I'm going to switch things up a little bit with my content a little bit. One of the things I was thinking of, because I have the day in the life, the doctoral journey, and one of the things I want to do is start talking about different scenarios that you'll see in the hospital. If depending on what setting that you work in, different things like that. So the first scenario I want to go over are amputations. Specifically, I'll go over what we call BKAs and AKAs. So below the knee amputations and above the knee amputations. And what's the difference with that? Literally what it says, where the location of the amputation is. Below the knee can be pretty much, it can be like right under the knee, so it has like a little bit of calf left over. It can be ankle, mid shin, things like that. Above the knee is literally just above the knee, anywhere from like just right above the knee to like pretty much like just close to the hip. So there's a long range of where these amputations be taken, will be taken. The reason why they differ in height is a number of different things, whether it's bone quality, whether it's blood perfusion, pretty much like how the blood is going through the veins, whether it is the quality of the veins. There are a number of different reasons why the doctor will have, decide, BKA, AKA, things like that. Now, do they go straight for the, hey, your toe is hurting, we're gonna go for AKA? No. Obviously, I'm not an orthopedist, so I can't speak from their standpoint. What I can speak from is doing the least amount with the best result possible. So, for instance, oftentimes I'll see patients and it's like, oh no, they had something going on with their midfoot, so the middle of the foot. So they'll try to take just past the midfoot. So think about it this way. So if this is your whole leg right here, all right, and from here down is not working. If I take from here, you still have a little bit that's not working. However, I go just above it, you have a little good blood perfusion over here, so it helps with healing down here. Does that make sense? So you want to be just above where the issue is to help with the healing process, healing properties, um, circulation, things of that nature. So if there's something going on with the midfoot, and like, okay, no, they'll see what's going on, whether they need to be weight bearing set, like the weight bearing status, whether you have to have like a cleaning done, different things like that. Um, they'll kind of go that route, and then they'll say, okay, we'll do what we have to do. Unfortunately, maybe a couple of surgeries. Because again, the more of a limb or a body part that you're sparing, the better it is, actually mentally, physically, emotionally. Because think about it. Let's say, cause I'm 35. Let's say if I had, a below the knee amputation, BKA. Let's say if it was, right above my ankle. Obviously, I've lived with my leg a lot longer than without it. So you're still losing something. You're still losing part of you. So we actually see the 5 stages of grief during amputations. Because think it's traumatic, physically, mentally, emotionally. It's a lot. It's life changing. Your life is altered. There's no if, ands, or buts about it. Your life is altered. So with surgery, they'll take as little as possible to get the best bang for their buck. Because again, the longer you're in surgery, the more complications you have. There's nothing perfect. No surgery is perfect. No healing is perfect. I've seen a lot of different things. I can probably make quite a few videos on just this aspect. So they take the least amount they need, take the best result that they can. Now, that's one of the things. Another thing is, who does the amputations? Is it a podiatrist? Is it a vascular surgeon? Is it an orthopedist? Is it cardiac? It depends. Depends on who's with the patient, different things like that, like how far up it has to go, different things like that. So it can be a number of different specialties that you'll see that are collaborating with the amputation, with the healing, things of that nature. Because I typically see my amputations on our vascular floor, on the on the vascular floor of the hospital I work at. So that's usually I see my amputations. I usually see I don't see a lot of like arm amputations. I usually see midfoot, AKAs, BKAs. Those are usually the patient population that I see on a vascular floor in regards to amputations. Um, so it all depends on what's going on. And one of the things I've been doing more recently, which I recommend that everyone do, is whenever you're doing your chart review, definitely. So if you're going, so do your chart review. Let's say if the patient had midfoot issues and they're non-weight bearing, because the doctor will put the weight bearing status in their notes, and then the evaluating therapist will put it in their notes also. So read the evaluating. So let's say if you're the first person to treat after the evaluation. So read the evaluating therapist note, see what the weight bearing status is, and then also, if possible, go back to the earliest, well, not the earliest, but the most recent surgeon's notes, whether it's podiatry, whether it's vascular, whether it's ortho, or all three. Read that note, because sometimes they'll put different things in their notes to update as much as possible. And also obviously talk to the nurse for the patient that you're going to see, because let's say if the doc saw the patient but they didn't have time to put their notes in, but they saw the nurse, like, oh, we got to do this and this, blah 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 blah. You want to make sure that your treatment plan is as up to date as possible, because you don't want to risk anything that's going on with the patient. Now, there are a couple of things that are with that. Actually, this was actually something interesting that happened to me not a couple months ago. I read the most recent therapist note. I was like, okay, cool. Patient is doing good. Patient was non-weight bearing, so they're not allowed to put any weight on that leg for the healing and everything like that. And there would be different weight bearing precautions. You have non-weight bearing, weight bearing as tolerated, toe touch weight bearing, partial weight bearing, different things of that nature. I can get into that in another aspect. They had their patient was non-weight bearing, so then I looked at a podiatry note and it said the patient was weight bearing as tolerated. So I was like, oh, what happened with that? Then I went to the nurse and they said, oh, the patient's gonna have surgery. Unfortunately, you have to amputate. So they're like, okay, so if it's going to be gone anyway, then you're not going to hurt anything by putting weight on it. So let's just keep the patient moving for circulation, for mobility, and actually just for mental clarity also, because being stuck in a hospital room is not good for anybody. So sometimes moving is as much mental as it is physical. So check the most recent therapist note, check the most recent surgical note, whether it's podiatry, whether it's ortho, whether it's vascular, whether it's cardiac. Check that most recent note. And then also you want to check in with the nurses. Always check in with the nurses before you go see a patient. No matter how familiar you are with that patient, check in with that nurse. Even if you try to see the patient earlier in the day and you had to come back, still check in with the nurse, because things happen fast. Particularly in a hospital setting, and I work mainly like a progressive care, and I also work in ICU. So particularly in ICU, check with the nurse. There are times where I saw a patient oh yeah, patient at 10 o'clock, patient's good. Yeah, patient's good to go. They're eating breakfast. Okay, cool. I'll come back later. Don't go in. Don't even go in there. Things change fast. So always check in. Now, things to know about I'll start with BKAs first. So with the BKA, depending on where they cut it, your body wants to be in the most comfortable position possible. And being stretched after a surgery like that is not comfortable. So your body may want to kind of, the person's hip may, flex a little bit. Their knee may flex a little bit depending on where the amputation is. So they're like, I'm not so you have to really coax them into into getting into certain positions that are appropriate for their next stage, if you will. Typically, a lot of patients, they do want to go the prosthetic route. So there's a lot of things you have to know about patients' health, their cardiac system, how mobile they are, to say they even qualify for a prosthetic. Now, a prosthetist, or a person who does orthotics, they will actually measure the patient for prosthetics or orthotics, get them measured for that, talk to them about what the process looks like, that's a pretty interesting field, to be honest, too, because you're actually making the prosthetic. So that's a whole different thing. It's pretty cool. So they'll talk to them about that, see, just to kind of like pick their brain a little bit. With you want to make sure that the leg is as straight as possible. Because you want to make sure that the prosthetist is measuring appropriate. Because again, there's a leg length discrepancy if your knee is bent and your hip is bent compared to if your hip and your knee are straight. It's a big discrepancy. So you want to make sure that the patient is able to keep their legs as straight as possible, also to prevent contractures. So to prevent contractures and to make sure that the next stage in life that they're going, that they will be as mobile as they possibly can for what they want. I like to put it that way because not everyone's meant to be, a sprinter. Some people just want to be able to move. So you want to make sure that their strength, their quality, so on and so forth, is where they're going to need to be. So a couple of things that you'll see. Want to make sure the leg is as straight as possible. You don't want a pillow under the knee, because again, it can bend the knee. So let's see, I like analogies. So let's say if this is the pillow and this is the leg. If the pillow is here, the leg's going to fall into a position like that. So it's going to stay bent. So if you're able to bring the pillow here to straighten the knee out, so that way when the patient stands up, they're like this instead of like this. Does that make sense? So you want to make sure that the leg is as straight as possible to make sure that the patient has as good of a chance of getting into a proper fitting prosthetic. Another thing that you're here, depending on patient's condition, comfort, things of that nature, is let gravity do its job. Again, gravity is very good at doing what it's supposed to do. So if a patient is able to, have them lay on their stomach. Lay on their stomach and just say, hey, lay on your stomach and just relax. And that way gravity is actually pushing the leg down to get into a more advantageous position for the future. Make sense? So have the patient lay on their stomach for a while. Again, different surgeons have different protocols, so always follow the surgeon's protocol first and foremost, because they know what the bone quality looks like, the patient's temperament, their oxygen stats and everything like that. And that's why you're also checking these things as you're going. And depending on which floor you're in, again, my last amputation patient that I saw was in ICU. So I have all the vitals right there, I have all the monitors right there, so I can just take a look and say, okay, patient's tolerating this perfectly fine. Go ahead and try this position, so on and so forth. So if you're able to have the patient lay on their stomach, have the patient lay on their stomach a little bit. Let gravity do its job. Let gravity stretch the legs out and make life easy on yourself. That's with a BKA. With an AKA, very similar. Again, obviously they don't have the knee, so I don't have to worry about the knee. But you want to have them have that leg stretched out as much as possible. Now, the position of comfort is actually having the pillow under the thigh. But again, you want to make sure that leg is as straight as possible to be as optimal healed as possible for the future. Mobility. How mobile is the patient? Is the patient bedbound? Were they walking before? The walkie-talkie? Different things like that. What does the mobility look like for the patient? So with transferring, because again, we want to make sure the patient's able to transfer, depending on what the status is. Again, where I was, my last patient, they're walkie-talkie, so they're very mobile. So we had to teach them hey, how to stand up with one leg. Use your walker, so on and so forth. Use your walker to walk around for a little bit, and then move as much as you can. But also while they're walking, pay attention to the foot the leg that had the amputation on, because oftentimes they'll keep that hip bent. Again, for comfort. So it's hey, just keep your leg straight. It can be a lot of body strength, but keep that leg straight. So you have them, you have to be very cognizant of their leg position, of the residual leg position. That's what we call it, the residual leg. Should be very cognizant of what that position looks like, because again, for future healing, future prosthetics, things of that nature. Phantom limb sensation is a real thing, and make sure that you're telling your patients that it's okay, because they're going to be depressed, they're going to be sad, some of them will be laughing, because again, People go through literally all stages of grief in the same treatment session. Literally the same. They'll go through all 5 stages of grief, and it's intense. Phantom limb sensation will feel weird. You may feel like pins and needles. You may feel like water. You may feel just pressure. The weird thing is I've had a lot of people say, yeah, my foot itches. And then they're like, oh, I don't have a foot. So their brain was just playing tricks because their body is used to having that limb. So they'll go through all those stages of grief and it's like, what the heck? It's intense. It's intense. So tell them that it's okay, that it's going to be emotional. Be honest with your patients, because people know that if you're lying, people know that you're lying. So be honest with your patients. Like, hey, this sucks. I'm not gonna sugarcoat it. This sucks. It's rough. But does it get better? It can get better. It definitely can get better. So tell them about phantom limb sensation. Another thing with phantom limb sensation, this makes standing very dangerous. Because again, you're used to standing with 2 legs, not 1. So be very, very careful whenever patients are transferring and changing positions. Tactile cues. So you had a limb cut off, but with the nerves. With the nerves, blood vessels. The legs are going to be extremely angry. The nerves are going to be on fire. They're seeing all these different signals that's going at it. Bam, 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 all these different signals. Again, that's why patients may feel their foot itch, they may feel water, they may feel heat, they may feel ice picks. They'll feel all these different sensations, going on because the nerves are pissed off. Straight up, nerves are angry. So one of the things that we tell your patients is whenever you're emotionally ready, and sometimes you have to do it before you're emotionally ready, is just gently take hands and touch around it. Touch around the leg. Don't touch where they cut, because again, depending on how fresh it is, it's still healing. So you don't want to touch exactly where the scar is. We'll leave that to the surgeons to tell you when to touch that area specifically. But touch around it, with just your hands, light touch, light pressure, just so your body's like, okay, I can breathe. It reduces the heightened sense that your body has. And then as you're used to that, try different textures. So whether it's like, put a glove in your hand, touch your leg with the glove, a towel, touch your leg with a towel, a hairbrush, brush your leg a little bit. So your leg is getting used to these different textures again. Because think about it, if your nerves are already angry, imagine putting pants on. And each time the wind blows and pants touch your leg, wipe your leg. It may not see like a lot for us now, for people who either have never had an amputation, people who've had an amputation for a while. Now, if you had an amputation before, again, leave your experience in the comments. I love to read about it. I love to hear about it, and just to just make sure that I'm on point. Because again, I'm speaking from this side of the hospital bed, not on this side. So, touch your leg with different textures, just to get your body used to it. Because if you're wearing a prosthetic, then that's a whole other thing. You have like a sock, you have a shrinker, you have the weight of the prosthetic. It's a lot. It goes into prosthetics, and then depends if you're a BKA or AKA. They have different connections and things like that. It's intense. It's a lot of stuff. So you want to make sure that you give your body the best chance of being as mobile as possible for whatever your particular goals are. Again, if you are a very active person and you want to be able to use prosthetics, you want to be able to make sure that your body is prepared for prosthetics. If you're like, I want to just be in a wheelchair for the rest of my life, be in a wheelchair for the rest of your life. Whatever your personal preference is. I'm not judging whatever your preference is. So get used to touching with different sensations, things of that nature, just so your body can get used to it. Healing is person dependent, nutrition dependent. It's a lot because again, you have to make sure that you're eating properly to heal properly. Bone takes about 6 to 8 weeks to heal properly. The pain will diminish before then, but bone takes about 6 to 8 weeks to heal. Talk to your people. If you need to talk to a therapist if a patient needs to talk to a therapist, a mental health therapist about this, have them talk to a mental health therapist. If you feel comfortable enough to be that mental health and physical therapist, occupational therapist, PTA, CODA, whatever your trauma is, let them talk to you about it, because it's a lot, and they are going to go through all these different feelings. Like, I remember I had this one patient. They had a very low BKA, very very low. So they had the majority of the way, and they were distraught. And they're like, they're just laying down. I was like, hey, how you doing? They're like, I'm okay. And I was like, I literally sat down. I was like, let's talk. Let's just talk. What's going on? And they just talk. He's like, I'm gonna lose my job. I'm like, why you feeling like you lose your job? He's like, because I have my leg cut off. How am I gonna do my job if I don't have a leg? I'm like, what do you do? He's like, oh yeah, I do this. I scan this. I scan this. I scan this. Da 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 da. I was like, is your plan to get a prosthetic? He's like, yeah, but I'm not sure how it works. So he was so afraid of losing his job that he was legit depressed. So we legit just started talking about it. Hey, being mobile is gonna be tough, but it's something that we can learn. You can move around, like you can get a prosthetic, even if it's just like a foot. And wear some long pants and no one can even tell sometimes. Just because you had an injury or a life-changing scenario doesn't mean your life has to completely change. You have to learn how to work around it, and then it becomes a part of you, and then it becomes easier. Is it easy? No. Does it get easier? Yes. Just depends on how much work you put with it and how stubborn you are with the progress. To be honest, that's all it is. So talk to your patients about what they're going through, because they're going to be scared. They're going to be scared for different things. Talk to the family members also, because family members can, sometimes they do get a little touchy. They test your nerves a little bit, but family members are scared too. Family members have no clue what to do. And the thing that's tough is that as a healthcare provider, I see this stuff so often, I get immune to it. But this is their first time going through these things. So their nerves, their anxiety is on 10. So that's something that we have to think about also, because we're used to this stuff. They're not. If they're in ICU, ICU is a different beast. Depending on which ICU you're in, we call them the Christmas trees. Sometimes you'll legit have 10 pumps. You have 10 pumps. You have a line. You have all these different beeps and boops. People waking up at all hours of the night. Sometimes rooms are just legit all white. So imagine you're in a room that's all white and you're just looking up. And you have these things beeping and booping. You know what day it is, what time it is. Your body was whole, then woke up and it's like my leg's gone. It's a lot. So talk to your patients. Let them vent. Let them talk to you. Because sometimes that's just being able to give them encouragement is more beneficial than physical therapy is, to be honest. Because there are plenty of times where half of my treatment has been physical and the other half has been mental. I ain't gonna lie, straight up. Because patients need to know the mental aspect of it also. So yes, I covered, below the knee versus above the knee, the different surgeons that can do the procedure, transfers, exercises. We call them wheelchair dips. So have them sitting on the edge of the bed or on the chair, have their hands like here, like you're doing a dip, and just push up. Because those are going to be the same muscles that they're going to need while they're using the walker. Whether they're using the walker, whether they're using crutches, same muscles, same principle. So have them do their wheelchair dips as a therapeutic exercise. So, and also there's other exercises that they can do. And make sure they're strengthening the whole leg. So we have the residual leg, which is what's left after the procedure, and we have the whole leg, the leg that had nothing done to it. So make sure they're strengthening the whole leg, unless there's something going on and they have weight-bearing precautions on the whole leg. That's a different story. So make sure that they're strengthening the whole leg. Make sure, if they're in bed, make sure they're doing their glute exercises. Because again, the glutes are the strongest muscle in your body. And what are glutes' main job? Hip extension. What are you doing when you're standing up? Hip extension. So make sure you're strengthening your glutes. Make sure you're strengthening your whole leg. Make sure that the positioning sound leg. Make sure that the residual leg, make sure that's positioned properly. Make sure that it heals in a proper position and no contracture risk. Make sure you're talking to the nurses before you go in. Make sure you're reading the doctor's notes. I know there's gonna be some other things I'm missing because there's so much to amputations. It's not even funny. There's a lot. The big thing I'll say is making sure that they're sitting and standing with control, particularly sitting with control. I'm trying to think. There's some other things I'm forgetting. I know I'm forgetting some stuff. I'm trying to think. Oh, be a human. Have a sense of humor. Have a sense of humor. But have a sense of humor, but don't make the patient feel like you're undermining them, and make sure the patient knows that you hear them and that you see them. Because that's important that they feel seen because they just had surgery. But yeah, make jokes, laugh about things, be honest. I'm like I say, I tell my patients all the time, I'm like, this sucks. What you're going through sucks. It's rough. I'm not gonna lie. It's difficult. Yeah. It's gonna take a while. Yeah. Is it easy? No. But does it get easier with time and practice? Yes, it does. And then I say, so one of the first things I say before I'm particularly with someone who's had like a life-changing thing like that, I'm also going to go over what we call cabbages. I'm going to do that in another video. I may go over like generalized weakness, some other things. There's a lot of things that we cover. But no, this is legit what I did on Sunday. I was in the hospital. I introduced myself to the patient. If I remember, I was like, hey, so before you start anything, what questions do you have for me? No matter what question is, no matter how silly the question is, what question do you have for me? And then it's like, whether it's, how to move, how long it's going to take, how can I be independent, what questions you got for me? Let's talk. So I sit there and talk to my patients first, and I try to answer the questions. I was like, okay, I was like, did that answer your question? Because sometimes after you answer a question, more questions pop up. So what other questions you got for me? So we just start answering these questions. Okay, this, da 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 da. Try this, da 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 da. We'll keep going. Now, okay, cool. These are therapy's goals. What is your goal? And that's another thing I ask. I'm like, what is your goal? Is your goal to get a prosthetic? And sometimes they'll say yes. Sometimes they say no. They say yes. Like, okay, cool. What does your house look like? Do you have stairs? How far is it from this place to this place? Okay, cool. So now we have to walk a certain distance. All right, cool, dope. So we start doing some basic exercises in the bed, and it's like, hey, for your sound leg, do your ankle pumps, do your leg lifts, do your ABA adduction. So bring your leg out in and out to the side like windshield wipers. Sometimes I just say windshield wipers. Like for your residual leg. So let's say if it's BKA for your residual leg, keep your leg straight, bring it up, bring it down, bring it up, bring it down. Or if they can't do that, I'll say, hey, I'll bring it up, control it down. I'll bring it up, you bring it down eccentrically. So it's like, hey, I'll hold your leg up, bring it in, bring it out, bring it in, bring it out. For the hip ABA adductors, because again, if your hip ABA adductors help keep you standing upright. Okay, those are weak, you can kind of like do a little slash, a little hip dip type thing. So you gotta make sure that those are strong. So okay, cool. We did this. Okay, cool. Let's get to the edge of the bed. Do you need my help? Nope. All right, cool. Let's get to the edge of the bed. Any dizziness? No. Any pain? How's it breathing? Okay, I'm feeling good. All right, dope. Cool. I'm bringing the walker over. So I want to see how you do standing. I'm here. I'm your assistant. So if they can stand by themselves, they stand by themselves. If not, I give them a hand. Okay, cool. Make sure the path is clear. Open the door. If there's a chair follow, because I try to have the chair follow, particularly if there's family there, because sometimes family likes to be involved. Sometimes. So, like, hey, do you mind bringing the chair with us? So, I'm there with the patient. I'm guarding the patient depending on how much assistance they need. Okay, cool. Go ahead and push and keep walking. I want to see what you do. Okay, cool. See what they do. I'm standing right behind them. The family member's right next to me. Okay, cool. Yeah, okay, cool. So you did this. I want you to adjust a couple of things. Your foot placement. I want your hand placement here. I want your foot placement here. Okay, push the walker here. Hop this distance. Push it here. Hop this distance. Just so they know, because numbers placement makes a lot of sense to people. So if you can give people numbers, placements, specifics, it makes things a little bit easier compared to ambiguity. Sometimes ambiguity works, depending on what your goals are, but sometimes you have to be very specific. Again, know your patient. So we'll kind of go through those things, get back to your room, right? And then I ask them, like, how do you feel? How was it? Was it easier than you thought, harder than you thought, right about what you thought it was? Okay, cool. Okay, cool. What do you think will make it easier? What do you think will make it harder? And just kind of like troubleshoot, plan from there. Like, okay, cool. So next time, I was like, hey, therapy looks different now. So I'll say, okay, you're scheduled for therapy about this many times a week. You know, we try getting here, but sometimes things will happen, like whether you're off the floor, so on and so forth. But our goals are this, and this. Sometimes, depending on what's going on, we may just do exercises in the bed. Sometimes we'll walk this distance. Sometimes we'll walk a little bit further. Depends on if we have someone falling with the chair or not. Depends on how you're feeling too. So I try to give the patient as much information as I possibly can, just so they're not caught in the dark, and particularly after a life-changing surgery. So those are some of the big things I'll say. Again, there's also a lot of minute things about it, all sorts of things. Like surgery is very, very interesting. Yeah, but the big things I'll say is talk with your patient, make sure they're mentally okay, read the surgeon's notes, make sure you talk to your nurse, and be a human with your patient. Those are some of the big things I'll say from this video. I'm thinking about doing, whether it's like cabbages, we call them cabbages, coronary artery bypass graft, heart surgery. So I'll either talk about that, generalized weakness, shortness of breath, different things that we'll see in ICU. There's a lot of things I can talk about. I'm not sure why it took me this long to break down these things, but I'll go over some more things. I can also talk about hip and knee replacements. I used to do a lot of those because when I was a rehab tech, I did what we call our joint cam. So I saw mainly hip and knee patients. So I'll probably talk a bit about that too. But if there's anything else that you guys are interested in, let me know. Drop me a like, comment, subscribe. I'd love to chat with you guys. But until next time, later.